So Ashlynn and
Good.
Dr. Brenner, if you'd like to turn off your videos until you're introduced, that's fine.
And good morning, everyone. Thank you all so much for joining us for today's virtual Lunch and Learn. We're just going to allow a few moments to have people to transition from our waiting room to our meeting space, and we'll get started in just a few minutes. All right, it looks like we have just about everyone transitioned over from our waiting room area. So let's go ahead and get started. My name is Sable Kay. I am the Acting Director of the Office of Health Equity, and I'm super excited to be partnering with the Office of Family Health Services for today's virtual Lunch and Learn on human milk feeding and learning more about the Human Milk Bank here in the Commonwealth of Virginia. This is going to be a very exciting time for us together. We have some incredible speakers for you all, and just in terms of housekeeping, at the beginning of our time together, we're going to have everyone's lines muted, but we encourage you, if you have any questions or comments or something interesting comes up as you're listening to our speakers here today, that you would put your comments into the chat box. And we have the wonderful Doreen Fleming from the Office of Family Health Services who is going to be monitoring our chat box, and we'll be able to address those questions during our Q&A session today. So a little bit about equity and its implications for human milk feeding. I think it's so important to make sure that we embrace a common language, and that we often utilize the terms equity and equality interchangeably, but they really are quite different concepts. Equality is a one-size-fits-all approach where you give everyone the same thing regardless of their needs or ability. Versus equity, on the other hand, is a tailored approach when we have individuals who you make sure that you give people what they need, when and how they need it. And the Office of Health Equity really embraces that tailored approach. And it's so important in this concept of human milk feeding, because we know that there are some specific factors that can make it more difficult for individuals to engage or to receive the benefits of human milk feeding. These factors are often the social and life conditions, often called the social determinants of health, that can impact healthcare outcomes and healthcare access. And there are several different social factors that impact human milk feeding, such as educational attainment, income, marital status, age, and race. And we are hoping that we can advance policies and implement programs such as the one that you'll hear about today that can help to mitigate some of those factors and increase the access to those across the Commonwealth of Virginia to human milk feeding. So with that, I would like to introduce our two speakers for today. We have Dr. Michelle Brenner and Ashlynn Baker from the Children's Hospital of King's Daughters, who will be sharing information with us on human milk banking. Dr. Brenner is a pediatrician and breastfeeding managed specialist who serves as the medical director of King's Daughters Breast Milk Bank. She is joined by Ashlynn Baker, director of King's Daughters Milk Bank. Ashlynn also serves as a board member for the Human Milk Banking Association of North America. Ashlynn, Dr. Brenner.
Good morning. Thank you very much for the opportunity to be here today. I'm going to have Ashlynn share the slides. Perfect. Excellent. Well, again, thank you to everyone for being here this morning. Thank you for the kind introduction. Thank you for taking the time out of your busy day to learn a little bit more about human milk banking in Virginia and about the King's Daughters Milk Bank here in Norfolk. While it's unfortunate that we all can't be together, one of the blessings of COVID has been learning how to take advantage of these virtual meetings, often sparing time and significant travel, and specifically for us, the Hampton Roads Bridge Tunnel. I would hedge to say that 12 months ago, we would not have been able to pull off this Zoom Lunch and Learn and reach so many of you at one time. So for this, we are quite grateful. I'm joined today by Ashlynn Baker. As mentioned, she's the Director of Operations at our milk bank and the day-to-day brains of our operation. When Ashlynn and I talk about what we do with people, we're often initially greeted with bewilderment, as most people are not aware of the concept of milk banking. This is often followed by curiosity, ending in appreciation and inspiration for what milk banking can achieve. We'd like to start today with a quick presentation, a 90-second video virtual tour of the milk bank.
The King's Daughters Milk Bank is operated by Children's Hospital of the King's Daughters, a full-service, freestanding children's hospital. We are nonprofit and proud to be accredited by HMBANA, the Human Milk Banking Association of North America. To ensure the safety and quality of our milk, we adhere to HMBANA's rigorous, evidence-based guidelines for donor screening and milk processing. Each week, pre-screened donors from all over the country send us thousands of ounces of milk to pasteurize and deliver to medically fragile infants. After completing careful processing and quality assurance protocols, our treatments are shipped to neonatal intensive care units and hospitals throughout the United States. When milk supply allows, we also fill prescriptions for pasteurized donor human milk treatments for infants and children with medical needs in the home. In our first 5 years of operation, we received more than 1.5 million ounces of life-saving human milk from our generous donors. From donor screening to milk processing and pasteurization to packing and shipping, the King's Daughters Milk Bank delivers high-quality human milk treatments to infants in need. Your breast milk can save lives. To learn more about obtaining pasteurized donor human milk for your NICU, or if you're interested in becoming a donor, please visit our website or give us a call.
Thank you, Ashlynn. So we're grateful that that milk bank video was completed prior to COVID-19. The bank has pretty much been on lockdown since March, but the opportunity to share our physical plant with everyone is exciting, just to actually get a look at what we do. So briefly today, we'd like to share the benefits of human milk for infants and discuss a brief history of the King's Daughters Milk Bank at CHKD. We'd like to examine the safety in donor screening and describe the qualities and safety of milk processing procedures that we use. And last, we'll evaluate the utilization of pasteurized donor human milk in our hospitals in Virginia. Again, I'm Michelle Brenner, and I'm the medical director of the King's Daughters Milk Bank. I've been with it since we opened in 2014. I'm also a general academic pediatrician here at CHKD, where we train the majority of all of our pediatric residents and the majority of the EVMS medical students in ambulatory pediatrics. I've also been a lactation consultant since 2002. So as you know, breastfeeding, while it has sustained our species for millennia, has not been the infant feeding norm in the United States. While it was the primary source of infant nutrition in the early 1900s, it reached all-time lows in the 40s and 50s due to women entering the workplace, as well as the development of human milk substitutes. When breastfeeding rates began to increase again in the 80s, research in breast milk also picked up. Prior to that, there were very few studies annually regarding human milk. By 2005, the American Academy of Pediatrics noted the considerable advances in recent years in the scientific knowledge on the benefits of breastfeeding and the mechanics underlying these benefits. They challenged their members to promote, protect, and support breastfeeding. In this 2012 American Academy of Pediatrics policy statement, they noted, given the short and long-term medical advantages of breastfeeding, infant nutrition should be considered a public health issue and not only a lifestyle choice. It really became a clinical imperative to help improve the lives of infants. The AAP then and now recommends exclusive breastfeeding for 6 months, followed by continued breastfeeding as complementary foods are introduced, with continuation of breastfeeding for 1 year or longer as mutually desired by mother and infant. So as you can see from this list below, breastfeeding has demonstrated many benefits to infants, particularly reduced infant risk of many illnesses and chronic diseases. The most important in my day-to-day practice include the prevention or minimization of respiratory tract infections, including respiratory syncytial virus, ear infections, and gastrointestinal infections. These are particularly problematic for infants in daycare during that first month or first year of life, particularly in the wintertime. But breastfeeding has also demonstrated a reduced infant risk of many chronic diseases, including celiac disease, asthma, allergies, eczema, diabetes, sudden infant death syndrome, caries, malocclusion syndrome, all kinds of things that you might not suspect, as well as situations and conditions such as leukemias and myelomas. So why human milk? So not only do infants benefit from mother's own milk, but breastfeeding mothers also benefit from these benefits. We know that moms experience decreased risks of hypertension, hyperlipidemia, heart disease, diabetes, rheumatoid arthritis, ovarian and breast cancer, to name just a few. We know that breastfeeding is also linked to lower rates of abuse and neglect, as well as postpartum anxiety and depression. These benefits to moms are cumulative, so the more infants she breastfeeds and the longer duration of breastfeeding, the higher the rates of her long-term protection and benefit. Economically, breastfeeding and human milk nutrition has a significant impact. And as I mentioned, in that first year of life, with so many upper respiratory tract infections and ear infections, if infants are in childcare and infants get sick, parents often have to miss work that day. And so we know that providing infant milk or human milk for those infants can certainly impact the business case for breastfeeding, which has been a large promotion to help employers realize the benefits that they could provide to moms with supporting breastfeeding. We know that up to $13 billion could be saved if 90% of mothers could breastfeed exclusively for the first 6 months. So where does pasteurized donor human milk come in? In the March 2012 statement from the American Academy of Pediatrics, they noted that the potent benefits of human milk are such that all preterm infants should receive their mother's own milk. Mother's own milk, fresh or frozen, should be the primary diet. If mother's own milk is unavailable, despite significant lactation support, pasteurized donor human milk should be used. So we like to think of mother's own milk and pasteurized donor human milk as a complex human infant support system that can provide many life-saving benefits for preterm infants. We think of human milk like a medicine, and for preterm babies, particularly in the neonatal intensive care units, it is linked to drastic reductions in the top 2 conditions that harm these infants: necrotizing enterocolitis and overwhelming sepsis. Human milk is also linked to decreased mortality rates, improved feeding tolerance, decreased lengths of hospital stay and readmission, decreased risk of retinopathy of prematurity, as well as chronic lung disease. In 2011 and in 2017, the Surgeon General and the AAP really reached out to identify and address obstacles to providing safe banked donor milk for these fragile infants. The AAP went on to say that donor human milk should be used in high-risk infants and should not be limited by the individual's ability to pay. and that policies are needed to provide high-risk infants access to donor human milk on the basis of documented medical necessity and not financial status. So, the Human Milk Banking Association of North America was founded in 1985. Since that time, there's never been an incident of disease transmission or a negative outcome in an infant due to the processing or distribution of pasteurized donor human milk, according to their guidelines. In 2017, the American Academy of Pediatrics, AAP, also endorsed that donor milk represents a safe, effective approach to obtaining, pasteurized, and dispensing human milk for use in NICUs and other settings. That families and caregivers should be reassured by the reports that there has never been an infection or a recall with regard to infectious diseases. On this slide, there are the logos of all of the different supporters of pasteurized donor human milk. Each of them have a statement with regard to the support of the use of donor human milk for the preterm infant, and many of them recommend milk from HMBANA milk banks. HMBANA is the nation's only professional accrediting association for milk banking. And again, since 1985, we've led the industry in quality and safety for milk banking screening, processing, and testing nationally and internationally. We've modeled our stringent safety criteria for donor screening on that of the blood banking industry. And the safety guidelines established by HMBANA were evidence-based and written under the advisement of the CDC and the FDA. And I will now turn it over to Ashlynn to talk about the specifics of the King's Daughters Milk Bank.
Thank you. Such a great opportunity to be able to share with this audience today. Thank you, Jareen and the Virginia Department of Health and the Office of Health Equities for arranging this. My name is Ashlynn Baker, and I'm the director here of the Milk Bank. I'm also a HMBANA board member. My previous experience before helping to establish this milk bank was in NICU nursing. I was a NICU nurse and also a lactation consultant. So my passion for helping medically fragile and critically ill infants to heal and successfully make it home is what drives me in milk banking as well. So I'm going to start by talking about donor screening and milk handling. But first, as Dr. Brenner was discussing HMBANA, I wanted to show you a map of the 30 HMBANA milk banks in North America. You can see where they're established in the blue and where they're in development in the green. Our milk bank was established here in Virginia in 2014. Today, the King's Daughters Milk Bank is the first and only donor human milk bank in Virginia. We were number 18 of the now 30 nonprofit milk banks in North America. What's very exciting is that we're one of only 2 milk banks affiliated with a children's hospital throughout all of North America. We're located within the Children's Hospital of the King's Daughters, Virginia's only freestanding children's hospital, home of a 70-bed level 4 neonatal intensive care unit, and we're accredited by DNV. Since opening in July of 2014, the milk bank has received over 2 million ounces of donor milk, with 1 ounce feeding as many as 4 premature infants. It's an amazing outpouring of generosity from our donors. We currently serve over 20 Virginia hospitals, but also serve hospitals stretching from New Jersey to Florida. We've assisted many of the hospitals throughout the state with implementation of their donor milk treatment protocols and training of their staff. We also provide pasteurized donor human milk to medically fragile infants throughout the Commonwealth and the home setting by prescription. We frequently collaborate with WIC and local Department of Health on initiatives, on events, and tours and education. And we also serve as a resource center for both medical professionals and the general public regarding the benefits of human milk and especially breastfeeding. The FDA often refers to us as a hybrid. Are we medicine or are we food? Well, we like to think of ourselves as a medical food and like a medicine for premature babies. So we are registered as a food handling facility with the US FDA, as well as accredited by the Human Milk Banking Association in North America. All of our staff members are trained in current good manufacturing practices, or CGMPs. Each member has a food handler certificate, and we follow a rigorous food safety plan. Our multidisciplinary staffing includes food safety managers,
preventative quality control individuals or PCQIs, registered nurses, a registered dietitian, lactation consultants, and a physician. We also have a panel of milk bank consultants, including specialists in the areas of neonatology, pediatrics, obstetrics, microbiology, infectious disease, pharmacology, nutrition, nursing administration, government affairs, legal and risk management, as well as both supplier and consumer representatives. We like to think that as a hospital-based human milk bank that we go above and beyond just HMBANA's accreditation requirements because we have this wonderful hospital where we can refer to experts at any given time throughout the day. Donor qualification and screening requirements. HMBANA milk banks follow recommendations and evidence-based research that support recruitment of the altruistic donor who goes freely and voluntarily without receiving reimbursement. We know that safety is enhanced when payment is not rendered. And per the World Health Organization, the CDC, the FDA, the American Academy of Blood and Tissue Banking, and HMBANA, the voluntary, non-remunerated donor population is the lowest risk donor versus compensated donor types. The screening process for donors begins with a medical and social questionnaire. Each applicant goes under both a verbal questionnaire as well as a written form of questionnaire and screening. The written confirmation of health is required for both the applicant physician and the baby's pediatrician. After completing the verbal screening, the donor completes an online screening, and the online screening includes HIPAA releases for both mom's OBGYN and her baby's pediatrician. We then reach out to mother's OBGYN or the donor's OBGYN and have the OBGYN complete a confirmation form. The confirmation form assures us that mom had negative and non-reactive serologies during her pregnancy, that she has no known risk factors for donation, and that the provider recommends this mother as a donor to our milk bank. For the donor applicant's baby's pediatrician, we also want to reach out and make sure that her own baby is growing and thriving well, that her baby's meeting developmental milestones, and that her baby's making it to the well baby appointments. All applicants also undergo risk screening for alcohol, nicotine, marijuana, and other substances of abuse using the validated tool created by the government, the TAPS1 tool. Guidelines surrounding drug screening mirror those of the blood banking industry. Applicants are usually also feeding their own infant, and the written confirmation of health form also alerts us to known risk factors in the mother-baby dyad. When I say usually feeding their own infant, there are cases where a mother is donating after the loss of her infant, so it might be a legacy donation for a bereaved mother. The mother may have been a surrogate and wants to continue to experience the benefits of pumping and lactation, so she donates. Or the baby may have something like cow's milk protein intolerance, and mother is starting an elimination diet, but has a freezer full of milk that would go to waste if she didn't donate it. So that's a wonderful reason to donate that milk. At present, there is no FDA-approved method for drug testing of breast milk. There is one current kit on the market, but it's labeled for forensic use only, and it's truly originally designed for the testing of serum like blood, saliva, or urine. Human milk is very complex and it has a lot of fat in it as well, so it makes it difficult to use a kit not designed for human milk or for drug testing. In addition to all of our risk screening and the validated tool that we use by the government, the TAPS1 tool, all batches of donor milk are pooled to provide an additional layer of safety. Each batch of donor milk is comprised of donations from at least 5 to 10 mothers and is diluted and pooled in the amount of over 500 ounces in total. Donor qualification and screenings also require that each donor undergoes blood testing. So we know that mom was negative and non-reactive for infectious diseases during pregnancy based on the confirmation of health that we received from the mother's OBGYN, but the milk bank takes it another step further, and we pay and arrange for the mother to be tested for diseases that could be transmitted through breast milk. We test for 2 different forms of HIV, HTLV, hepatitis B, hepatitis C, and syphilis. Now we know mom is also negative negative for disease during her lactation period. And finally, the quality assurance team here at the Milk Bank reviews each and all donor applicant screening records and results for final donor approval. Final donor approval also includes the approval by our medical director, the physician of the King's Daughters Milk Bank. So we have the OBGYN, the physician of the mother, signing off that this mother would make a great donor. We had her own baby's pediatrician signing off saying that mom would make a great donor. And then the quality assurance team, including our medical director here, reviews the screening records and approves this mother as a wonderful donor choice for the Milk Bank. Donors receive ongoing education and initial education as well regarding proper hand and pump hygiene, milk collection, storage, and transportation procedures. They're also provided with education regarding risk factors that may disqualify them from donation. All donors have frequent ongoing screenings, and they have a screening with each donation. These screenings assure us that there's been no changes in their health status or risk factors between their approval period and the time of donation. Nationally, we're also required to screen these mothers at least every 2 months to assure that there's been no changes in their health status. Being a regional Virginia milk bank with most of our donors coming from the state, we have the ability to establish wonderful relationships with each and every one of our donors. You can see from the pictures throughout the presentation, our donors are very close with us. They call us often. We share the highs and the lows of being a breastfeeding mothers, and we often get to know their families very well. Donors who are approved have the option to either drop off if they're local or ship their donations to the Milk Bank using priority overnight shipping. We provide the prepaid FedEx air bills and all of the materials and instructions, including a visual picture checklist on how to pack their milk safely for transit so that their milk arrives to the Milk Bank perfectly frozen and ready for us to inspect and process. Each package of donor human milk that comes from the mother is inspected, it's labeled, barcode for risk and tracking, and stored in our hospital grade freezers until the milk is pooled and prepared for processing. All donor milk processing is performed in our hospital-based donor human milk processing lab with staff wearing PPE at all times. All donor milk is strained, it's pooled and blended in large stainless steel vats before it's bottled. The donor human milk is dispensed into BPA-free polypropylene bottles sealed with a tamper-evident seal and labeled according to FDA regulations, processed using the Holder method of pasteurization. The time and temperature profiles used for our method of pasteurization, the Holder method of pasteurization, are defined by the US FDA and HMBANA to ensure destruction of potential pathogens, including but not limited to SARS-CoV-2, Ebola, Marburg, Zika, CMV, HPV, and HIV. So we know that mom was negative for diseases that could be transmitted through breast milk through her prenatal serologies and that confirmation of health. We also know that she was negative and non-reactive for diseases during lactation through the blood screening that we perform. But an additional layer of safety is that we gently pasteurize the milk, and that process has been proven to eradicate diseases that could be transmitted through breast milk. Let's talk a little bit about COVID-19 and pasteurization. I'm sure that's something that you're interested in. I'm going to refer to two different studies here. The first study was in Journal of Pediatrics and Child Health in 2020, where they inoculated samples of human milk with high levels of SARS-CoV-2, simulating a theoretical worst-case scenario. The samples were then pasteurized using the Holder method of pasteurization, the same method that we use here at the King's Daughters Milk Bank, and found that SARS-CoV-2 virus was effectively inactivated by our method of pasteurization. Another study that was by Sharon Unger and team showed that the pasteurization method of 62.5 degrees Celsius by 30 minutes, the Holder method of pasteurization, inactivates SARS-CoV-2. Thus, in the event that donor human milk contains SARS-CoV-2 by transmission through the mammary gland or by contamination, This method of pasteurization renders milk safe for consumption and handling by healthcare providers. To take it one layer further in safety, we also culture every single batch of donor milk using multi-TOF. It's the most advanced microbiological identification system available. We test for Bacillus, E. coli, Salmonella, Pseudomonas, Staph aureus, yeast, and mold. All cultures must be negative before we will dispense milk to infants. Another great tool that we have here in our milk bank is we have one of the first FDA-approved human milk analysis machines. So we're able to analyze each batch of donor milk, assuring that proper calories and protein are provided to hospitals, especially for babies in the neonatal intensive care unit. The report that we provide to the hospital is called an MBAR, a milk batch analysis report. So that healthcare providers caring for these infants know that they have high quality donor milk to provide to their infants, their patients. Our quality assurance team also reviews and verifies the processing records and the pasteurization records to ensure that we meet our time and temperature requirements, that our culture reports are negative, and that our nutrition analysis reports are adequate. Milk distribution. Approved, culture negative, pasteurized donor human milk is dispensed by prescription or hospital order. Each bottle of pasteurized donor human milk requires an FDA compliant label with identification by barcode to be scanned at dispensation. Here at the King's Daughters Milk Bank, we carry a strict system of tracking and recall, and mock recalls are performed frequently. Shipments of pasteurized donor human milk travel by priority overnight shipping with dry ice, and we even include cold chain verification trackers to assure the hospitals that breaches did not occur through shipment. Let's talk a little bit about Virginia distribution. It's exciting to report that more than 78% of our donations come from Virginia residents. 80% of our level 2 and level 3 NICUs throughout the state are using pasteurized donor human milk provided by the King's Daughters Milk Bank. We also serve several mother-baby units or level 1 newborn nurseries throughout the state, also helping them to reach exclusivity rates and their Joint Commission Perinatal Core Measure PCO5. In fiscal year 20, our inpatient distribution was about 215,000 ounces of donor milk, of which 66% of that milk made it to Virginia hospitals. Also in fiscal year 20, our outpatient distribution was roughly 72,000 ounces of pasteurized donor human milk, of which 76% of that went to Virginia infants in the home. And in conclusion, the King's Daughters Milk Bank at CHKD would like to extend our partnership and our collaboration with interested parties to ensure safe and ethical standards are maintained while improving access to pasteurized donor human milk to disadvantaged and fragile communities. Now we'll open it up for questions.
Good morning. I am Jareen Fleming. I'm your state breastfeeding coordinator, and I'm so happy that we've been able to partner with the Office of Health Equity to have this fascinating presentation. And now I would like to invite you all to have a conversation with us. So if you would like to turn on your cameras to do that, you're welcome to, or you're also welcome to chat your questions into the chat box. So I've been letting people in as we go along, Jasmine, so if you could monitor that for me. And I have a few questions that were sent in advance to give you time. If you would prefer to chat your questions in, you're welcome to do that. And we also have the capability of unmuting yourself if you would like to direct a question to Dr. Brenner or Ashlynn Baker. So you spent quite a bit of time, Ashlynn, talking about how you're able to, how you test your milk for any viruses or bacteria. Are you also able to test the donated milk for any adulterants?
That's a great question. Currently, there is not an FDA-approved method to test milk for adulterants, so we make it our priority and HMBANA's priority to follow the evidence-based research that supports using the low-risk, voluntary, non-remunerated donor to ensure safety. We also go over handling and requirements and storage of pasteurized donor human milk as well with our donors.
Thank you. So in the chat box, I was, as the state breastfeeding coordinator, I closely monitor how we're doing as a state. And I'm happy to let everyone on the call know that our CDC breastfeeding report card, which basically reports on what infants or how they were being fed in 2017, 2018, was released this summer. Virginia is doing very well so far as our initiation rates, even our duration rates to 3 months and 6 months as compared to the national averages. But the area that we need to work on and focus on now is exclusivity. So thank you, Dr. Brenner, for talking about why an exclusive human milk diet is so important. So I am curious to know what type of feedback or what you've seen that human donor milk to be used as a bridge to when there's some problem in getting mother's own milk well established to help us with our exclusivity rates, which we have a higher than expected supplementation before 2 or 3 days of life. So what do you think about that as using it as a bridge?
So I think that using donor human milk as a bridge is becoming much more popular in our mother-baby unit. I think what it does for families is it demonstrates the value that we place on donor human milk and the exclusivity. It just really reinforces that this really is the best nutrition for your baby, and that it's not just nutrition, it really is medicine. And so I think that message is heard by families very strongly. They recognize that the introduction of formula certainly is not the same. And I think it helps them in their decision and their commitment to move forward with pursuing an exclusive breast milk diet.
I'd like to add a little bit to that as well. With the newborn nurseries that we're serving now, we are getting great feedback. And I do want to say that the consenting process is really key. It stops healthcare providers in their tracks to talk about the benefits of a human milk diet. And for families who were undecided about whether they were going to breastfeed or not, when they're offered, a hospital says, well, it's so important that we're going to offer pasteurized donor human milk. A lot of families are really, their eyes open up. And if it's so important that this hospital is going to offer donor milk to my baby, then maybe I should just try to latch and feed my baby or express milk for my baby. So I think it's a great tool for units as well to increase mother's own milk rates.
Thank you. So we've got a question in the box. What is the reason for limiting breast milk donations to those that have been stored for less than 9 months in the deep freezer?
That's a great question. So for kitchen freezers, our duration for expiration is 6 months. For deep freezers, it's 9 months. It gives us a longer window of use. When we pasteurize the milk, we get to add an extra year to the earliest pump date for the expiration. So we do get to extend the expiration. We've gently removed anything that could cause the milk to spoil, but it allows the hospitals, the end users, to have more time to use the milk, so a longer expiration.
So this is interesting. Can you, it's sort of a little piece of my previous question. Can you explain the benefit of donor breast milk as compared to formula? Since the donor milk gets pasteurized, which could kill the good bacteria. Well,
Sure.
the formula shouldn't have any bacteria. Okay, so go on.
It often does. Ashlynn, I'll start this and you can certainly chime in. So again, the Holder method of pasteurization is a gentle feeding that does eliminate the pathogens that were listed previously, but also retains the benefits of many of the aspects of donor milk. And again, breast milk is not just a form of nutrition, which is what formula is. it is just this amazing immune support system for the infant. So it does retain many of the active properties that can help the infant fight infection. The lactoferrins, the lysozymes, different components in the milk itself that actually help fight infection. So formula feeds babies and grows babies well, but it certainly does not have all of the anti-infection and immunologic benefits that human milk for our species was designed to have.
I agree with what you said. The bioactive components are largely preserved through our gentle method of pasteurization, but it's also exposure to human growth hormone, human protein, and human antibodies. An infant's not going to receive that in any other form if they do not receive mother's milk or the second best option, which would be pasteurized donor human milk. Species-specific nutrition is key.
So I have there's a question on the cost of milk for recipients, and you briefly mentioned that it is also available outside of the hospital in a home setting. So I would imagine that that question is directed for that.
I'll take that.
It was actually for in the hospital as well.
Oh,
so
thank you, Ebony.
Yeah. So my question was in looking at health inequities and health disparities. We know that African American mothers tend to have a higher incidence of premature or preterm births, and the necessity of having access to this milk can sometimes be limited. And so I wanted to see, is donor milk, is it covered by insurance for even babies that's in the that's still within the hospital setting, and then even cost following. Is this covered by insurance? Are there any programs that help parents who may not be able to afford it? And have we been looking at disparities along the lines of who actually are using these milk donor programs, who's donating, and who's actually receiving?
Right. Great question. So hospitals that use pasteurized donor human milk, at least in Virginia, it's not reimbursed by insurance. So hospitals that offer it as a gold standard form of nutrition for their infants, and provide it as part of their budget for the patients. It's something that we definitely would like to see covered by insurance, since there's so many both acute and chronic benefits, short and long-term benefits in prevention of acute and chronic diseases. So this is something that definitely needs insurance reimbursement. We definitely don't want it limited by just hospitals that can afford to cover the processing fee for the patients. From an outpatient standpoint, there is coverage right now. TRICARE is leading the way in coverage of outpatient pasteurized donor human milk treatments for medically fragile infants. Otherwise, there is out-of-pocket expenses, or most banks, including ours, has a community benefits or a charity care program. But because of lack of reimbursement, we're being a not-for-profit milk bank, we are limited in our ability to provide that charitable care milk. So we try as best as we can to support the families of Virginia and getting treatments in the home. But Dr. Brenner, you could probably talk a little bit about coverage.
Yeah, so it would be really great in the future, again, for hospitals particularly that are absorbing that cost. The Children's Hospital of the King's Daughters, we began using donor human milk in the summer of 2012, and that's actually how Ashlynn and I met. One of our neonatologists wanted to introduce me to, that they had read the policy statement and they really wanted to do this gold standard for the preterm infants. And Ashlynn was in charge of the donor human milk treatment program at the time. It is labor intensive to do all of the screening that we do and the processing and the pasteurization. And so there is a cost to that. Hospitals right now are absorbing it, but it would be really great if it could be reimbursed for hospitals. And we help as many families as we can. The addition of TRICARE and that benefit for those families has been fantastic. And we've had numerous patients with short gut syndrome, end-stage renal disease, or just formula intolerance that we've been able to help through that TRICARE program.
And just curious, do you all have a with your metrics, does it break down along the lines of race? Have you looked and seen if there's any racial health disparities on those that are actually accessing this milk program?
As a board member for the Human Milk Banking Association of North America, I will say that there are disparities, and it is, the CDC has noted that. They did a report based on zip codes and found that safety net hospitals did not have donor milk treatment protocols. And I know that HMBANA nationally is working on equitable access to donor milk for all hospitals, but that really is going to be based off of insurance reimbursement as well. We need insurers to see the benefits of species-specific nutrition as a way to decrease healthcare costs, both short-term and long, and to help us advocate and make sure that each and every baby, not just babies in certain zip codes, have access to donor milk.
And one last question, and I'll stop because I know I'm asking a lot. So, do you think we need to tackle that on the federal or state level as far as policy formation? Would that be your recommendation?
For sure. Dr. Brenner, do you want to talk a little bit about House Bill 442 from last year?
Yes. So House Bill, I believe it was 447, was an attempt to get donor human milk covered for hospitals. It certainly was an early attempt at this, and I think there needs to be a lot of additional study that goes on by the different committees in order to get that approved. The concern this year with COVID-19 and the budget restrictions, it will be interesting to see if we can move this forward this year.
Absolutely. With the King's Daughters Milk Bank providing over 80% of the level 2, level 3, level 4 NICUs throughout the state, we'd be more than happy to share numbers and help the state to narrow down what a budget would look like to potentially cover the cost of these treatments so that more babies would have access.
So this is a question for Ashlynn. Have you ever had a donor qualify initially, donate, and then find that they were required to requalify? When they were required to requalify, they became infected with a virus or seroconverted?
We have extremely high quality donors here through our non-remunerated donors, and they are so frequently in contact with us that we have not had that case come up, but we do have a very strict tracking and recall system that we would be able to not only analyze and hear from the donor quickly, be able to defer her from donation, but in the case of a recall, we would be able to do that in minutes.
Can you elaborate on gently removing the components that allow milk to spoil?
So the method of Holder method of pasteurization, which is 62.5 degrees Celsius for 30 minutes, is known as the gentlest method of pasteurization. It's not high heat, it's not high pressure, it's not high temperature. So there are different methods. There are sterilization methods that actually can put the milk under high pressure and high heat for different durations of time. But internationally and nationally, the evidence shows that the Holder method of pasteurization is the safest method with the best evidence for use in human milk.
So we have a question here about how does one go about establishing a donor milk program in a hospital? And if you wouldn't mind actually going all the way back to the origins of the King's Daughters and the history that's there. You know, I'm a Virginian, we love history.
So cool. Yes. Every time I tell the story, I get goosebumps. But we started the milk bank back in 2014, but we started the treatment protocol here at our children's hospital in 2012. And as we were getting the staff ready and implementing the protocol, within a few months, I was asked by the King's Daughters, the organization that started our children's hospital, to meet with them and discuss what we were doing. And honestly, I thought they were going to be like, oh, they're using donor milk. Explain to me why this is safe. But I didn't know until we went to that meeting that In 1915, the King's Daughters, they had a milk and ice fund, and it actually was a group of women that rode their bicycles around downtown Norfolk delivering milk and ice to infants and children in need. But they had found in their archives during the same period of time that we are establishing this treatment protocol that they would collect hand-expressed breast milk in mason jars, hop on their bikes, and race that milk to the sickest babies in Norfolk. So when I met with the King's Daughters, here it goes, I get the goosebumps again. When I met with the King's Daughters, who call themselves the Circles of the King's Daughters, I wasn't prepared truly for what they were going to be asking. And they said, what you're doing takes us full circle to our mission of how we started the Children's Hospital. And they asked if I would have a hand, and if Dr. Brenner would have a hand, and several other people in our hospital, if we could make this happen and to start a not-for-profit milk bank in their name and take them back to where their mission started. So that's what led to the initiation of our milk bank. But starting a treatment protocol in a hospital, it takes, there are several steps, and I have great kits and tools to share with you. So if anyone's interested in establishing a donor milk treatment protocol for their NICU, for their special care nursery, for their mother-baby unit, or to learn more about the options for outpatient donor milk for some of your patients, I'd be happy to discuss that more offline and lead you through that process.
Thank you. We'll have you put your contact slide back up for a moment for that questioner so she can get in contact with you. And thank you, Sable K. Just put into the chat box also that was actually House Bill 367, donated human breast milk, payment of medical assistance. So, you know, I would encourage everyone to closely watch and see if that legislation, in my short time in state government, I see that legislation will be reintroduced several years before it passes, very much like our public breastfeeding law and our law that went into effect in July of this year to support workers. So that now in Virginia, we have accommodations requiring all employers to provide adequate or appropriate space and time for employees to express milk during the work period. And so that had been introduced several times. So I would encourage you all to, for situational awareness, the link is there. If you'd like to look at the LIS, you can see all of the bills that are being presented for this next circuit. I wanted to go back up. We're going to talk a little bit more about cost, because there was someone that that was actually supporting a client. So, okay, here it is. My client had very limited access, just a few days, to pasteurized donor milk with a child in the NICU. Is this common, or is it due to limited amounts? Thank you, Emily, for that question.
That was a great question. And to just talk about first limited amounts, the donor milk bank here, the King's Daughters Milk Bank, established in 2014, has never experienced a shortage. In fact, we not only serve over 35 hospitals, but we serve a large amount of outpatient families in the community. So if there was a shortage, it may have been possibly on the hospital side, not so much the milk bank side. And the duration of treatment. So most infants, most hospitals started their treatment protocol for VLBW infants and under. That's very low birth weight infants, roughly, I believe that's 5 pounds and under, born less than 32 weeks gestation. And they typically feed these infants with pasteurized donor human milk until at least 32 weeks, but more likely 34 to 35 weeks gestation to get them past the risk factors for necrotizing enterocolitis, which is the leading cause of death for premature infants in the NICU. So it depends on what gestational age your baby was at birth. We know that more NICUs are starting to offer pasteurized donor human milk to all infants in the NICU, and they're not restricting it to very low birth weight infants because they've seen the benefits of donor milk for infants like gastroschisis or congenital heart disease, phalloceles, feeding and difficulties and intolerances. So the benefit is far exceeding just the VLBW population or the extremely low birth weight population. and it's being expanded, but each hospital has their own protocols, and these protocols may be restricted due to lack of reimbursement from the insurance side of things. So that's likely the case, possibly, depends on the gestational age and what restrictions the hospital has in place.
I just saw my colleague at the Division of Community Nutrition is on our call, Vinitha Padma. I wanted to introduce her to you all because Vinitha was, would you like to say anything, Vinitha? Not to put you on the spot, but if you wanted to say hello, you're welcome to unmute yourself.
Hi, Jareen. Hi, everyone.
Hi.
Hi. It's great to be here to listen to all the benefits of human breast milk, human milk. And it feels great. I was part of it. And when I gave birth to my first child, my firstborn, and I was able to donate too. So it feels nice. So that's all I can share right now.
Vinitha, thank you for sharing your precious milk with so many premature and critically ill infants in need. It was so wonderful to work with you and still have you active with us.
I'm not active, hopefully in future.
Yeah.
Yes, my child is going to turn 2 years by next month.
Well, we look forward to that phone call to celebrate the next baby with you, hopefully.
Thank you for those wishes. Hopefully, yes.
I just wanted to give Vinitha a shout out because she works with us in the WIC program at DCN and was also a donor to the milk bank here. I also wanted to invite those of you on this call who are interested in being abreast of everything related to human milk feeding in Virginia is to check out the Virginia Breastfeeding Coalition. They meet monthly, they share information, and they also advocate for supporting any practices or programs in the Commonwealth to promote human milk feeding. Let's see, I had a couple more questions since we have a few more minutes. I think you may have addressed this already. You did. Here's the question. Do you have the ability to do a full recall if there is a potential issue with your donor milk? So is it barcoded?
Absolutely. Each and every bottle is barcoded. Each bottle is scanned out at distribution. And we have a very strict policy and process in place for tracking and recall. That's not only a requirement here at our hospital, but it's also a requirement for our National Accreditation Association, HMBANA. We often provide HMBANA, especially during inspection and accreditation, but at all times we provide mock recall scenarios, and we can perform a recall in minutes using the system that we have in place.
Thank you. And also just giving that history, I just put the coalition, the Virginia Breastfeeding Coalition link in the chat box. Let's see, there were two pieces. Bryant, would you like to, okay, so there were two pieces of legislation regarding milk banks last year. House Bill 367 includes provisions for payments of medical assistance and also additional licensing and regulation for banks. And then also House Bill 442 is the bill Dr. Brenner was referring to relating to health insurance coverage of donated human milk. So thank you for that clarification. Rachel, are there opportunities to work with the milk bank? I have donated before, but would enjoy finding an opportunity to work in this area. I'm also planning to become, maybe you should
definitely email us.
Yeah, Ashlynn,
there unfortunately are COVID restrictions right now with volunteers and our bank's locked, secured location. But in the future, when things improve globally with the pandemic, we do have volunteers who come help us with tasks around the bank. Nothing related to the handling of the donor milk or the donors, but there are things that you could help us with around the bank. So definitely reach out to us. And thank you so much for being a donor and sharing the health with babies in need.
So I think our very last question will be regarding food labeling. So you mentioned that your protocols were put in place based on guidance from the CDC and the Food and Drug Administration. Are there specific food labeling requirements that you?
Yes. As a food handling facility registered with the FDA, we have requirements that we need to meet for labeling, which we do include that on our label, including barcoding as well. So we meet those requirements, and those requirements also by HMBANA.
So again, thank you, Sable K. Nelson Dyer and Dr. Brenner and Ashlynn Baker and all of you who are on this lecture today for being here, for helping us to raise awareness about the importance of human milk feeding in the Commonwealth and beyond. Thank you so much, Dr. Hilton, for your very specific questions around disparities. We know that access to baby-friendly hospitals there's a great disparity in that, where those hospitals are located, and in relation to minority communities in accessing that type of care. And so I would, imagine that if we took a closer look, we would also continue to see that in access to donor human milk. So let us all keep that in our minds as we work to create policies and systems to support it. Thank you again. This was recorded. It will be posted in the Virginia Department of Health website, and I will endeavor to share that link when it's available to all of you who participated today, so that you can share it with your colleagues and your professional circles. Thank you so much. Have a good day. Happy upcoming holidays, and be safe. Wash your hands and wear your masks.
Thank you, Jareen. And certainly call us for additional volunteer opportunities, particularly in research areas. We certainly have some donor milk and would be happy, that's labeled for research use, and we would be happy to collaborate with folks on that as well. But thank you so much.
Thank you so much. Good day, y'all.
Breastfeeding babies.